My name is Cameron. The title of my project this summer was the Efficacy of Hypertension and Self-Management Classes among Low-Income Patients of a Federally Qualified Health Center. And we submitted that mouthful as an abstract to the American Heart Association, and we currently have the manuscript in progress. So of course, owe a lot to everyone on the slide, most of all Dr. Brady Granger, who was my mentor. So thank you to all those folks. So as we all know, Black Americans have a higher prevalence of hypertension than other racial groups. And so our aim with this project was to close those racial disparities by focusing resources on patient education, skill building, and self-management. And so we wanted to, working through Lincoln Community Health Center in Durham, accomplish that and sort of facilitate those patient education programs through the patient site of care at Lincoln. And we thought that, our sort of operating theory was that doing so could help improve the sustainability of those healthy habits related to hypertension for patients, help Lincoln as a provider be more responsive to patient needs if they're able to keep up with their patients in the classes in addition to in their appointments, and it could also potentially lead to policy change in reimbursement and outcomes reporting, which I'll talk a bit more about later. So the part of the program we focused on were these weekly hypertension classes that were held at Lincoln, where patients learned about hypertension, were trained on taking their own blood pressure, and were given blood pressure cuffs to use at home. And so our analysis sort of focused on trying to identify the patient factors that may have contributed to successfully, engaging with the class, coming to multiple classes, and also just reducing their blood pressure. So as far as results go, the most important thing probably to know, at least the first thing, is that participants who came to multiple classes did have an average reduction of 20 points systolic and 15 points diastolic in their blood pressure, which is really great. So because it worked, we want to know why certain people came multiple times, why other people came once and decided it wasn't for them or couldn't relate or wasn't inaccessible to them for whatever reason. So this table sort of pulls apart people who only went to one class and people who went to multiple classes. And you can see that people who were older, people who were Black compared to Hispanic, and people with who were already monitoring their self-monitoring their blood pressure before attendance were more likely to attend multiple classes. And that didn't reach statistical significance, but people, as you can see at the bottom of the table there, who attended multiple classes tended to have higher blood pressure at baseline. So, some of these things make sense. People with higher blood pressure are probably more worried about it, so they're more likely to go to a class. People who are older, more likely to be retired, more likely to have time to go to a class. But there's more to dig into, I think, in the racial component and the self-monitoring components. So some of our main takeaways: none of the 27 Hispanic patients who participated were self-monitoring their blood pressure prior, and then very few of them attended multiple classes. So this sort of lines up with what exists in the literature. The Hispanic populations have lower awareness and concern over hypertension than other groups. So there's a lot of work to be done in raising that kind of level of consciousness among Hispanic communities. And then in addition, the intervention proved to be beneficial to patients' health, but there's really no sustainable path forward for these classes because of the reimbursement landscape. So since it's a non-clinical activity, no insurers are involved in it, not really pay for it at all. So as we move to population-level payment models, it's important that we sort of carve out a role for these kinds of education programs. And similarly, quality reporting standards also act as a sort of further disincentive because they disallow measurements taken outside of the clinical setting, such as those taken at these classes, from being reported. So basically, Lincoln goes above and beyond for their patients and can't get credit for improving those outcomes. And so there's a lot of further work to be done on how we can best incentivize these kinds of educational activities, which is a lot of the work being done here at Duke-Margolis. And that's my references. So thank you. Happy to take any questions.
Great. Yeah, thank you, Cameron. So actually, I do have a question that's not specifically about this work, but if I remember correctly, Cameron, so you are not at Duke, right?
That's right. Yeah, I'm a Master's
at,
of Public Health student at UNC.
Okay, so I didn't know. I was wondering what kind of next for you in terms of either continuing this work or kind of next steps on your end.
Related to this work, I'm hoping to continue to help out with this into the fall as we work on the manuscripts related to the project, and then help to iterate the program in its year 2, so we can try to capitalize on some of these findings and how we can sort of reach patients better and try to counteract some of these findings about who's more likely to engage. So I'll be helping out with that as we move along here.
Great. Okay.
Thanks. Yeah, I wanted to also say thanks to Cameron for the flexibility this summer, as we had sort of initially planned to be able to be in the field taking blood pressures with patients, and all of that shifted. So I just want to say thanks, because you've done a great job of changing platforms and changing objectives a little bit. Thanks.
All the thanks goes to you.